And welcome to the Dr. Bob Show. Are you bothered with knee arthritis, osteoarthritis, wear and tear arthritis? Do you have pain and swelling and difficulty walking? The more you walk, the more your knee hurts. Has your doctor tried to treat that and now says, I think it's time for a total knee replacement or knee replacement? Do you know what the indications are for getting knee replacement? We'll be talking about knee replacement, spending most of that time on this show. My guest is Dr. Herman Botero. Dr. Botero is a board-certified orthopedic surgeon, and he'll be answering our questions on knee replacement. A lot of information he has for you and for me. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about dementia. What is dementia? It's not a disease, it's symptoms. And we'll be talking about good news and bad news about dementia. If we have time, we'll be talking about signs and symptoms of gallbladder disease. Where is the gallbladder? A lot of information we're both going to find out tonight. We're talking with Dr. Herman Botero, board-certified orthopedic surgeon, and we're talking about knee replacement, total knee replacement, and a new type of surgery for that. Herman, welcome to the Dr. Bob Show.
I'm excited to be here, Dr. Bob. Thank you for having me.
So tell me about knee arthritis. What is knee arthritis?
Well, knee arthritis, or as we say in the industry, osteoarthritis, is the most common type of arthritis that affects our joints. It probably affects somewhere around 30 million to 40 million Americans.
Wow.
And what it is wear and tear of the cushioning of the joint that we call cartilage that happens with time.
So with time, the cartilage wears away?
It wears away.
Dries up,
wears away particles.
and that's osteoarthritis there.
And that is osteoarthritis.
Symptoms?
The symptoms are pain, swelling.
What kind of pain?
The pain that patients complain of is an ache. It's a deep ache that typically is around the joint, and it's associated with the activities that they're doing. So typically at rest, they may not feel the pain, but as they become active, as they stand or walk, and the more you do of that, the more pain they start to have.
Swelling?
Swelling is also very common. It tends to come about also with activities. And the swelling is due to an overproduction of synovial fluid that we normally have in our joints, but it's overproduced due to the wear and tear of the cartilage.
So the synovium lines the joints and makes it where it moves and wiggles good.
Correct.
And when it swells, it hurts?
It does. The swelling, which is also called an effusion, can be quite tense. It causes pain, and it also further limits the motion of the joint. And so as the fluid takes up space in that joint, the joint is very difficult to move.
So eventually, what's the treatment for osteoarthritis of the knee, and when does the patient know they're going to need knee replacement?
Well, sure. Well, unfortunately, we have no cure for osteoarthritis. There is no cure. There are only treatments and treatment modalities. The very first one is things that we do intuitively. We modify our activities. So obviously, if you're doing something that hurts, you figure it out, and now you start limiting the things you do. At first, you may have to give up running. But as the disease progresses, you start giving up more and more.
And so eventually you give up walking almost?
You may have to do that.
Yeah.
It can get to that point, and many patients do, and they suffer for it.
And they suffer for a long time.
Correct.
And then what's the treatment?
Well, the first medication type of treatment that we use is a medications or a group of medications called NSAIDs, which is an acronym for a non-steroidal anti-inflammatory drugs. These are your ibuprofen, your Aleve, Motrin. These medications help reduce inflammation.
And they have some side effects. They irritate the GI tract. They can do other things.
They do.
But they'll help that swelling and that pain.
But they sure do help the swelling and the pain. They decrease the inflammation, and therefore there's less pain and less fluid buildup.
Next, if that doesn't work, and if my knee still hurts and it's swollen and I can't walk down a hill, what goes next?
You come on in to the office, you're coming in with a painful knee that's not responding to the fact that you've modified your activities, you've been taking your Motrin diligently, not working, you come in with a big swollen knee, that's where we have to go and tap the knee, and we take...
Does that hurt?
It's actually very, very well tolerated. I mean, we do lots of injections, and so we're very good at it. And so it's almost painless most of the time.
Every time I see a patient that said I had to have my knee injected, they said, it didn't bother me at all.
Right.
And it felt so good.
Correct.
For how long does that injection work?
Well, we take fluid out, which in and of itself helps with pain, and then we inject typically a combination of medications, a numbing medication, and a steroid, a corticosteroid.
And what do they do to that swelling and irritation and inflammation of the knee?
Well, corticosteroids are very, very strong anti-inflammatory agents. We make some of these ourselves in our glands, but now we're injecting them into the joint, and it really does help reduce inflammation. And it could potentially reduce the pain and the inflammation for months. However, it can be dependent on how far advanced your arthritis is. So the more arthritis or arthritic your knee is, perhaps the less likely it is to work for a long period of time.
Do you frequently, can you inject the knee once a month for 6 months?
So it's really, there's really no great data to say what is the number or how often. We know that if we do too much, that in and of itself can be detrimental to the tissues. So I think maybe like baseball, someone came up with the 3 strikes you're out methodology. And so we tell patients that we want to try to avoid these injections for maybe giving them every 3 or 4 months, maybe 3 a year.
So when you see a patient that comes in and says, my doc says I need knee replacement, what are your thoughts? Is he a candidate? Is he a good candidate or not? You do that by history, physical? How do you determine that?
Exactly. History, physical, and then x-rays. Typically, those are the things we're looking at. We want to make sure that the patient has, that we're treating, we have to make first of all, we make the diagnosis. We got to come up with the appropriate diagnosis that this is osteoarthritis. Once you've done that through history and physical, you want to see where they are in terms of their treatments, their conservative treatments. Conservative treatment options are there, and we want to make sure that we have exhausted them.
What does the x-ray look like?
So
normal knee, an arthritis knee.
Sure. So in the normal knee, we're looking at the knee joint, and the cushioning you cannot see on x-ray, but the cushioning on x-ray looks like a space. And so you should have a nice space between the 2 bones that make your knee joint, which is your thigh bone and your shin bone. And as long as you have plenty of cushioning or cartilage there, you will see a nice gap.
When you get the arthritis, what does it then look like?
Well, as you start developing arthritis and the cartilage starts to wear away, that gap starts to narrow. And when you have end-stage arthritis or severe osteoarthritis, that's when you start to see what we call bone-on-bone arthritis on x-rays. No gap, the 2 bones are right on each other.
So that begins to tell you right away that patient's going to end up needing possibly knee replacement.
Correct.
Is knee replacement beneficial to patients that have bone on bone.
Absolutely.
And that's what we're going to be talking about. Absolutely. You're going to be surprised at how simple the procedure can be sometimes. And Dr. Botero does a special type that you're going to want to be sure that you watch. A lot of information. I can't wait. We're talking with Dr. Herman Botero, board-certified orthopedic surgeon, and we're talking about total knee replacement. It's people that have osteoarthritis, wear and tear arthritis, where the normal joint with lots of space ends up being worn away, and you get bone on bone. And when it's bone on bone, it's probably time for total knee replacement. Is that right? Absolutely. So tell me about when the patient comes in. What's total knee replacement like?
Well, it's an operation that's been around for a long time. And obviously, over the years, it has changed quite a bit. But it is an operation that involves a fair amount of trauma. Essentially, what we're doing in knee replacement surgery is we are going inside the knee joint and we are cutting away the arthritis. And what we cut away at the ends of the bone, we replace with implants that are essentially made out of metal and plastic.
So the implant is a metal implant that you're going to insert into the knee. Do you have to open the knee up and bring it out in space like this, or are there newer techniques? What do you do?
Sure. So traditional knee replacement surgery, and the way we've all been taught for many years, involves making an incision down the front of the knee. And then once you get into the deeper layers, you make an incision into the capsule and then into the quadriceps tendon or muscle.
So the quadriceps tendon or muscle, where is that? You've got a good picture here.
Yes. So the quadriceps muscle and tendon is the main workhorse for your knee. This is the muscle.
This is the thigh and this is the knee.
Correct. This is your thigh bone.
Leg, rather.
This is your shin bone. The knee joint is here. This is your quadriceps muscle, which is your workhorse, a tendon, kneecap, and a tendon. And this is the main muscle that helps your knee function. With traditional knee replacement surgery, the deep approach is made along this tendon, splitting it, or into the muscle. Once you split that tendon, that allows you to dislocate the kneecap and expose.
So the knee's right behind the patella right there.
Correct.
And that's with a knee replacement there.
Yeah, this is showing a knee replacement model. And so traditional knee replacement is mainly done with the surgery with the knee flexed. The knee is bent. That gives you the exposure to the two bones that make the knee joint. Once this is exposed, you go ahead and make the appropriate cuts to place your implants. So traditional knee replacement, the surgery is done with the knee flexed or bent. And in order to have exposure, you have to dislocate the knee.
Do you cut the quadriceps muscle normally in the old days?
In the old days, there's either cutting the muscle or splitting the tendon of the muscle.
Gotcha.
And both of those techniques allow you, again, to dislocate the kneecap and then subsequently dislocate the knee to make the appropriate cuts for the surgery.
So what are some of the newer types of minimally invasive?
So the whole idea of minimally invasive was, how do we take a procedure that has a fair amount of trauma involved and try to minimize the trauma of that procedure? And so it's actually been around for quite a long time. It's probably been around for over 15 years. And the minimally invasive approach, or quad sparing approach, what we're trying to do is we're trying to spare the quadriceps tendon and muscle. We're making our approach more towards the inside part of the knee.
So you don't have to flex the knee as the person
Right.
the knee straight away?
Right, and the reason why we do the surgery this way, the reason why we can get away with making an approach that ends about here as opposed to from here to here, is because we do almost the entire procedure with the knee in extension. If you have to bend the knee, this muscle and tendon are tight, so you have to cut it to get it out of the way. If you do the surgery in extension, then this complex muscle and tendon are loose. So you can just push it to the side, and now we have access to the knee joint.
Oh, and so your incision there would be much smaller?
Much smaller, yeah. Typically, we're doing these through incisions that are about 4 inches in length.
And you don't?
Yeah, as opposed to a traditional knee replacement that's 8 to 10 inches in length or more.
So the advantage to that is, can you put in the same hardware?
Correct. Dr. Bob, we're using the same exact knee replacement that's used during a traditional knee replacement, but we're using custom instrumentation that allows us to do the surgery with the knee in extension and therefore not have to completely dislocate the knee in order to do the same procedure. So what we're trying to do is we're trying to minimize the soft tissue trauma that occurs during a procedure like knee replacement surgery.
So it looks to me like the advantage is you've already shown us there. You're doing an extension. You don't have to invade the quadriceps muscle, and so the recovery time is going to be a lot better?
It's a lot better. Patients find that they get through their therapy, which is super important after a knee replacement, with an easier time. I tell my patients that they're looking at making about 90% of their recovery over the first 4 to 6 weeks, as opposed to a traditional knee replacement that can take you months to recover from.
So I've had some people tell me that when they've come out of your knee surgery that they can walk, almost go to Sunday school and church and do their activities the very next weekend. Is that too quick?
Not at all. Dr. Bob, 15 years ago, patients would stay in the hospital a week to recover and then go home. We are doing these surgeries now outpatient. For the last 2 years here in Knoxville, we have patients come into the surgery center. They have an operation that's done with a spinal and a block. It takes less than an hour to do the surgery. You're walking about an hour or two after that, and you go home within 4 to 6 hours.
Doesn't it hurt like mad? You've cut inside the knee. Do you put any medicine inside the knee to make it where it feels better the first?
We do. We call this multimodal management.
Multimodal management.
Pain management, yes. And so it's a combination of a spinal, a block, medications that we give through the IV or by mouth, and also injections that we do inside the knee at the time of surgery.
So you can do this outpatient now in a surgery center, and they go home that night?
That night, that day.
How much bleeding?
Very little. We do use tourniquets, but we also use a medication called tranexamic acid that has really revolutionized joint replacement surgery. I can't tell you I remember the last time we had to give someone a blood transfusion. It's really unheard of these days.
So far, that's amazing. Tell me about the recovery of that patient. You do outpatient, they go home that day, they're walking.
Right. We get patients up the same day. Typically, we start them out with a walker. We tell them to get rid of that walker as soon as possible. I'm a big fan of, being so close to the Smokies, of either a hiking stick or trekking poles because they give you better posture. And so they quickly move on from the walker to a walking stick or trekking poles, and they start therapy the very next day.
How long before you see the patient back?
I usually see patients back at around the 2 to 3 week mark from surgery.
And what are they like when they come back in 2 to 3 weeks?
Well, patients tell you they can't believe they waited that long to have the surgery. And so they're making quick progress. A lot of them are already telling you that their knee feels so much better than what it used to feel. And I have many professionals, dentists, physicians, lawyers who are very motivated to get back to work, and a lot of them get back to work within a week or two.
That's absolutely amazing. It must be a wonderful feeling to have somebody come in incapacitated and you do surgery, replace the knee, and they're back to work in a short period of time. That must make you feel wonderful.
It's very gratifying. A lot of patients tell you, thank you for giving me my life back. So it is very gratifying.
It gives me goosebumps. And that's what we go into medicine for, to help other people. Herman Botero, you're a wonderful teacher. You're just fascinate me on your ability to do knee replacement. Thank you for coming to the Dr. Bob
Thank you
Show.
for having me.
Isn't that wonderful? Total knee replacement. I didn't give Dr. Botero time to talk about hemi replacement. I wish I'd have had time for that. We'll get him back to talk about a hemi knee, a half knee, that's also indicated in some people with osteoarthritis. Again, Dr. Botero, thank you so very, very much. And now we're going to stay tuned. We're going to be talking about dementia. What is dementia? Well, we'll talk about that, and we'll talk about gallbladder disease. Where is the gallbladder, and what kind of symptoms does it occur? So a lot of information we've got to go for you. You'll want to stay tuned. I want to thank Dr. Herman Botero. Wonderful discussion on quadriceps sparing knee replacement. And now questions from you, the viewer, that I think will be important to your health. Dr. Bob, my doctor says I have dementia. What should I do? Dementia is not an illness. Dementia is a symptom. There are a group of illnesses that have dementia. Dementia is a progressive loss of memory, social skills, doing purposeful tasks like writing your checks and balancing checkbooks. People eventually can't do that. They have very poor social awareness. So there are several dementia illnesses. We usually think of Alzheimer's, but Alzheimer's, 80% of people with dementia have Alzheimer's, but there is vascular dementia, there's frontotemporal dementia, there's a Parkinson's type of dementia. So all of these will end up having a type of dementia. Now, with Alzheimer's disease, there are two protein abnormalities, tau protein and beta amyloid. They make the neurotangles. And so what we have is messed up synapses of the neurons, so we begin to lose our memory and social skills. And that's what happens with the others. The good news on all of this is that there are ways that we can prevent the progression or even the development. So there's a recent article in a journal of Lancet which talks about if we look at our problems with heart disease and the risk factors, and if we can get rid of those risk factors, then we'll get rid of the vascular problems that eventually will cause some forms of dementia, vascular dementia. So lowering your blood pressure is one of those ways. If we lower our blood pressure, then maybe we'll keep the dementia from progressing so fast, or if we start doing that early, may not even develop it. There are 5 different blood pressure medications. This article says it doesn't matter which one. Keep your blood pressure normal, 120/80. If you can do that, or whatever you and your doctor decide is normal for you, then it may be that you won't get dementia, or it won't be as bad as early. So know that there are things we can do now to diagnose early and to treat early where you'll do better. Question number 2. Dr. Bob, what is the gallbladder disease? Well, first of all, we say, where is the gallbladder? It's in the right upper quadrant. It's right under the liver. It stores bile. And so when we eat a fatty meal, if it's diseased, it gives us pain in the right upper quadrant. So we get pain. We may get nausea and vomiting. We may not be able to tolerate foods. We may even get jaundice because the gallbladder, if it's not able to empty, then we get jaundice. So if you have yellow eyes, right upper quadrant pain, can't eat fatty fried foods, then you've probably got gallbladder disease. Talk to your doctor about that. It's all the time that we have for this show. Remember those 4 things that we like. Exercise is the best thing you can do. It cuts down on stress. It will help you lose weight. It'll help protect you against Alzheimer's disease and forms of dementia. Eat properly, lots of fruit, lots of fiber. So be sure that you're eating properly. We all know how to eat. It's that we eat too much food. So eat small meals, eat frequent meals, more fruit, fiber, no fried fatty foods. 7.5 hours sleep. How important that is. There are several problems with sleep. If you can't get to sleep, or if you wake up, can't go back to sleep, those are sleep disorders, and you need to have specialty help. If you snore, the person beside you may not be able to sleep well. So know that 7.5 hours sleep is so important for your health. And last of all, what is it we like on the Dr. Bob Show? It's laughter in your life. If we laugh a lot, your immune system will work better. Studies will show that your immune system works well if you laugh a lot. People around you will be happier. Your life will be more fun. It will be easier. You'll be healthy and you'll be happy if you get sleep and happiness.